So thanks for returning for the second part of our fireside chat on telemedicine. Once again, I'm Barry Fields. I'm a sleep physician at the Atlanta VA, and I'm joined by other members of the AASM's Telemedicine Presidential Committee, Dr. Christine Wan, Mr. Dennis Kelley, Dr. Matthew Troester, Dr. Innessa Donskoy, and Dr. Marty Martin. So welcome back to all of you, and thank you for joining all of us. So once again, I have no conflicts of interest to disclose. And as a reminder, we started on our last video with group introduction. So if you missed it, check it out. And then we moved on to points of discussion like getting started and the physical exam. And now we'll cover other topics like billing and privacy and security and even more. And then we will wrap things up. All right, so let's head right back to the chat that we started previously. And I'm going to get right to it with billing. So lots of questions about this. So I'm going to ask Dr. Christine Wan to comment. So how do you get telemedicine billed and paid for? Who handles this in your office?
Yeah, that obviously is a big question that, really guides the feasibility of telemedicine in your practice. For us, I mean, we're really grateful that during this pandemic, the telehealth waiver allowed for a lot of flexibilities. So, we were able to see new patients or return patients under these guidelines. The reimbursement also, as it stands currently, is on par with in-person visits. So that is definitely reassuring and supports the telehealth practice. For us, again, being from a larger healthcare system, our billing is largely handled by a centralized billing department. And I think that helps us a lot because, as you know, the whole telehealth regulations were quickly evolving, and it was almost impossible to keep track of what was compliant, what was not, what needed to be dropped in terms of modifiers for billing. So this central billing department was really resourceful for us. And another way they've helped us maintain compliant billing is to have a templated documentation for telehealth that is, that fits all the requirements for a billable service. So for us, that would include, a consent, a documented consent for this telehealth visit. We'd also have to document where the patient was, in what location, what state, and as well as documenting who else was on the visit, the telehealth visit with them. So having all these components well documented in our EMR that gets updated in the background and automatically imported into our visit encounters has been enormously helpful. The other thing that was really helpful was initially we were billing telehealth by time. And that was the understanding that it was the only way to bill. But now it's evolved, and now we're allowed to bill telehealth based on medical decision making. And I think that's helped support a lot of the billable services that we deliver. Basically, that was how our institution tackled the billing, and it's still evolving. I mean, we're going to have to wait once this healthcare emergency is over. It leaves us with a lot of questions about how CMS will continue to support and reimburse for telehealth services. But I think it really is here to stay at this point.
Absolutely. Anyone else have anything to add about billing or challenges that you've run into?
I think the idea of having a checklist, like Dr. Wan suggested, is a great idea because it really helps the providers be able to focus in on what they need to be able to do and document for them, and it just makes it easier for them. I know we've done that with other types of reimbursement other than telemedicine, so that's a really great idea.
I always say it's hard to, it's better to teach people how to fish than to give them a fish. And by that, I mean, it's hard to come up with one rule and say, do these 3 things and you'll get reimbursed, or follow this rule and you'll get reimbursed. Really, it's best to do your homework. So speak to your insurance company, speak to your, your billing department or anyone in administration, and really make sure that the visits that you're doing will get reimbursed, because the fact is we're not looking to get rich off telemedicine, but we can't be losing money or else we're not going to be able to provide the service. So it's really up to us to learn how to fish, learn where the information is, what rules like parity rules are applicable to your state. Does your state require parity, that private insurers pay the same as whether it's telemedicine or in person during the pandemic, after the pandemic? What rules apply at this point in time? So it's very, very important that you do that. So kind of moving on from that idea about billing, I want to move toward Dr. Troester again and ask, what studies have you been doing, and has the ordering process and study review process changed with more telemedicine being used?
So for us, I mean, I think things changed a little bit with the pandemic. But as far as what we do versus telemedicine and not telemedicine, it didn't seem to matter. We would order, I think, more or less the same things. In pediatrics, we don't do a lot of home sleep testing. We do have watch pad. We have disposable watch pads, which turned out to be useful during the pandemic because they're one and done. But we stopped doing some of our cap trach studies. We stopped doing pap titrations, but we didn't stop doing anything else. We're back to normal now. But otherwise, as far as telemedicine goes, for what I order and what I don't order is pretty much the same, unless there's something I just can't quite figure out for the telemedicine exam. I might maybe do an EEG that I wouldn't do otherwise if I was really suspicious about epilepsy, as opposed to some sort of sleep terror or something. But otherwise, that's about it. It's about the same.
Anyone else experience significant changes with telemedicine since the pandemic? We really have stopped. We're just beginning in-lab studies again. We had to stop totally. So we were even mandated to stop home sleep testing. We have reintroduced home sleep testing, thinking about that, either having a disposable device or quarantining devices. So as patients return a home sleep apnea test device, letting it lie for 7 days or whatever is deemed appropriate where you are, to ensure that the risk is extremely low. And then, of course, using appropriate PPE to process that study. So just being very cognizant about that. I wouldn't be surprised if some practices, even after the COVID pandemic, use more home sleep apnea testing, because they're finding in patients where, and I know this anecdotally, in some patients with COPD or other disorders where we're usually very careful about home sleep apnea testing, we can actually probably use it for more patients than we think and kind of push that envelope a little bit now that we've gotten more comfortable using it successfully for patients who we wouldn't have considered using it for before, but keeping to the strict ideas that if the test is not sufficient, if there's poor data or any question about that data, that patient then needs to do an in-laboratory study. I mean, that is still the recommended practice, but we've seen some changes in prescribing of home sleep apnea testing that way.
And I will talk about it as a psychologist. There's certain psychological tests where there is some concern about whether it's appropriate to do it over kind of a telemedicine platforms, because if you look at the norm groups, it's all based on a person to person in the same room. And sometimes you can't get the same level of assessment as to how the patient is approaching it, regardless of the particular score of outcome. So I think that's one thing that psychologists are kind of wrestling with is it appropriate to conduct certain psychological and neuropsychological assessments using these type of platforms? The jury's still out.
Yeah, absolutely.
I think things that changed for us is we were very fortunate. Our engineering staff here managed to set up our sleep labs as negative pressure rooms. And so we can kind of use those a little bit more along with the PAPRs for the staff. And we stopped sending out portable testing equipment and used the WatchPat Direct system, where we contracted with them, and they were sending the equipment out to the patients and then bringing it back and being worried about the post-exposure sterilization and cleaning. and we would get the raw data back that our physicians could then interpret. So we managed to kind of keep up volume to a certain level, but it was a little bit more expensive, obviously.
Great, all sorts of adaptations, and it's been an interesting time. Dr. Martin mentioned appropriateness of telemedicine, whether some testing, psychological testing, and other testing is appropriate to do over telemedicine. And another question that has come up is controlled substance prescribing. How appropriate is that through telemedicine, and how do you do it? So I'm going to ask Dr. Wan from her perspective up in the Northeast, how are you handling controlled substance prescriptions through telemedicine or using a telemedicine system?
Yeah, that was, a major concern initially, whether CMS or other insurers, what kind of guidelines they would be putting forth for being able to prescribe and renew controlled substances, especially in our practice, in the sleep practice, we do often prescribe Schedule 2 and 3 medications. So for us, how we handled it is, for all intents and purposes, insurers have accepted telehealth visits deficient or in-person clinical visit in terms of, NCD, LCD qualifications, as well as substance prescriptions. So we're fortunate in that regard. How we've personally handled it is obviously we want to be vigilant about following up closely patients on controlled substances. So we do, frequently meet with these patients. And telehealth is actually an excellent platform, I think, for it. I mean, I don't understand any disadvantage for assessing a person's, efficacy on narcotics or other controlled substances, because a lot of it is history taking, and assessing for high risk behaviors or assessing for side effects. I mean, these are not done differently, I would argue, in person as it would be, over a video. And like I said, I think the telehealth option gives us the flexibility of visiting these patients even more. So keeping better track of their use and side effects versus, that labored once a year annual visit come in for a token visit to say, yes, I'm doing fine. So it actually has enhanced our program in terms of, following patients on Xyrem, on, narcotics, on benzos, benzodiazepines. I think it's just the issue of access. And so when you have patients with, potential side effects or potential abuse, I mean, I think that access is actually of benefit.
Very interesting how people are leveraging telemedicine to actually enhance the care in some ways and enhance the monitoring. Anyone else have any stories to share with controlled substances, prescriptions, any challenges you've run into, or any cautionary tales out there?
So in Arizona, we weren't allowed to prescribe any controlled substances to a new patient we met over telemedicine.
Interesting.
So what we would do was we would call the primary care doctor, ask them to prescribe the first round, and then even though we still hadn't seen them when they came back in a follow-up, we could then take the refills. But it's a very peculiar workaround to the problem.
And I've heard that before, other folks utilizing primary care providers or other individuals that have seen the patient in person to get the order done and then kind of taking over from there. But this all gets back to the common themes. Know your state, do your homework, know the rules, because it can be literally very costly if down the road it turns out that anything was done outside of that. So just another reminder. It's great. And I wanted to move back to a topic actually I think is also extremely important and we touched on before. I'm going to ask Dr. Martin to comment a little bit more. How do you handle privacy and security concerns?
Yep, so that's a good question. And I always have to remind myself, when you think about privacy, you think about the person. And when you think about confidentiality, I think about data and information. So let me go to the privacy first. So one of the first things I do with any patient, whether they're new or they're an existing patient, is I ask the question is, so, tell me where you are, where you're located. So I'm licensed in the state of Illinois. So if they say I'm in Wisconsin, then I obviously can't move forward. So if they say they're in Illinois, so I want to establish that. I also want to see, it's not uncommon that someone may be like in a coffee shop. Occasionally I've had people driving. So then I'll ask the question, I'm just curious, it looks like you got a little coffee shop background. I'll say, oh, I'm in Starbucks. And I'll say, well, is anybody around you? And then they, oh, look at all these people. So then that may not be the most appropriate setting. And even in the home. So similar to what Dr. Nesky said is, if I hear something or I see some people running back and forth, then I may say, is this the best time? Maybe we need to look at another time. Recognizing this, I may have some patients where they have little children and there's no other kind of caretaking responsibilities. So if they're like 4 or 5, if I say that, can we select another time? But if they say they cannot, then we kind of move forward. And I also want to make sure too, in my home, that it's private for them as well. So I have a little sign on the door, which says that I'm in session, and then people know not to come in. And then I also, telling kids is make sure you manage the dog so the dog doesn't start scratching on the dog. So I think the privacy goes both ways. So with regard to the security, again, is you can't promise that there will be no data breach. So I try to tell myself is what's under my control. So there's some administrative controls. So like a policy and a procedure. So I'm not an attorney, I'm not a bureaucrat. So I go to my medical malpractice carrier, they have some sample policies. You can also go like the American Telemedicine Association, they have sample policies. So I go and look at those policies, but they're HIPAA plus, they're not just HIPAA, but some other security provisions. The other thing that I do is technological protections as well. So am I using technology that has been validated or verified by some credible party, not a sales representative, that it is HIPAA secure? And I'm very cautious of any like guarantees. And then the last one is human control. So as humans, we get tired, we make mistakes. So do I, close my laptop? Am I good about changing my passwords on a regular basis? Do I have a filter on my screen such that if someone walks into the room, they can't see anything? I have like a little glass over there. So it's oriented such that you can't see my screen if you look through that glass. So I think it's a matter of having administrative controls in place, technological controls in place, and human controls in place. And to the point that Dr. Fields made is document that. Because if you haven't documented, regulatory bodies, licensing bodies, attorneys will say it didn't happen. So I think it's critically important to document it. So those would be my kind of comments about privacy and security.
All great points. And when individuals have asked me about these certain nuances with telemedicine, about privacy and security or anything, I really say, well, start, telemedicine is special, but it's not that special. So start with the basics, right?
Yes.
So how did you function before telemedicine? What steps did you take to make sure that privacy and security was maintained? Mm-hmm. And then you, in some cases, add to it, you adapt it to the telemedicine environment. So you start with that, and yes, document.
And that reminds me when you said that, because years ago when everything was paper records, yes, you made sure you put in a locked file cabinet, yep, and then you locked your office door, and then sometimes you would double check. So now you electronically lock everything down.
Exactly.
Yeah.
That's great. So let's discuss licensing. So you talked a bit about Illinois, and that makes me think about licensing in Illinois and other states. And I think the best person to comment on that, thinking of Illinois, is Dr. Donskoy. So Dr. Donskoy, tell us a little bit about any licensing issues that you've had to handle.
Well, yes, I am in Illinois, and a majority, if not all of my patients are also citizens of Illinois. So that has made the licensing part for those patients quite easy. But of course, when it comes to telemedicine, now we have this amazing ability to reach so further out and potentially have patients as self-referrals or consults who reside in other states. So to really figure out what is needed to care for a patient from a different state, I'm actually going to share my screen now and show a resource from the AASM website. Give me a moment. So I have no conflicts. So this is our AASM website, and there's actually a really nice resource here. If you go to clinical resources and then the telemedicine option, this actually takes you to the AASM's telemedicine webpage, which aside from what I'm about to show you, has a variety of very, very good resources for starting, implementing, billing, continuing, and following up with the telemedicine practice, both during the pandemic and after. But as you scroll down on this main page, you'll see two very, very helpful links. One is the Interstate Medical Licensure Compact, and the other is the Center for Connected Health Policy webpage. So if you click on the latter first, for the Center for Connected Health Policy, this is a web page that will allow you to see state by state what you need in terms of licensure to care for a patient from that state. So I happen to have Illinois selected here, but of course, what I'm really worried about is if I want to see a patient from Wisconsin, this comes up a good deal for us. What do I need to obtain in terms of licensure to care for a patient from there? If I'm going to proceed, then what I'll do is I'll actually go to the other link from the main page, the Interstate Medical Licensure Compact. And this site is actually going to show me which states are enrolled in this compact, which essentially allows for more expedited licensure between those states. There's few on it. Some are in the process, and you can see on the color-coded chart, some are lagging a little bit behind, but clicking on each individual state will allow me to know what steps I need to take or what steps I need to reach out to my licensing department to help me take and perhaps curtail the costs of to be able to care for a patient from a different state. So these are fantastic resources that the AASM really just lays out for us. And I think if this is a issue that's coming up for you in your practice, these are very good places to start.
Thank you so much for that and for showing us those resources. It gets back to what I was mentioning a bit earlier, the analogy. Dr. Donskoy has just taught us how to fish. So instead of telling us specifically about every single state, she has shown us and laid out there what the American Academy of Sleep Medicine provides, where you can look up your own state, and that's the homework that we're talking about doing, really looking at that information and being very careful with it. So that's great. And yes, the Interstate Medical Licensure Compact and that Center for Connected Health Policy site is incredibly helpful. Sometimes it has to catch up with current changes, especially during the pandemic, but a wonderful, wonderful resource for anyone to take a look at who's considering starting a program in telemedicine or continuing on and ensuring that your telemedicine is in compliance. So
and just
great
as an add-on, there's also a similar compact for psychologists, which is called PsyPact. So you can just Google that, PsyPact. So that's similar.
Great to know. All right. So we've talked a lot, especially in our last session, about sort of preparing for the visit. And if you haven't seen that, go back to our first session because there was a lot of great discussion. We've talked about the session itself, how to carry out the session. I want to move us now toward after the session. So this one I'm going to toss to Dr. Troester. So how do you track clinical outcomes? So PAP downloads, serial Epworths scores, things like that, using telemedicine.
So we've been really fortunate at our hospital in that our IT group has been very dynamic with us in building into our notes a way to track the Epworths sleepiness scale score or STOP A, or whatever you want to use. The PAP downloads, we don't have a way to track it other than using ResMed AirView or Philips Care Orchestrator, whatever you use. And we have a place where we type it into our note. But beyond that, I will say the one thing the pandemic has allowed, at least where I live and with pediatrics, is patients who I did have to actually get an actual card, an SD card, and put it into my computer and read it. I've been able to get all those people switched over to telemetry type devices where they don't need any of that anymore, which has been great because that eliminates that whole I forgot my card compliance issue. So that's been a really wonderful thing. The pandemic has just opened that up for us. But other than that, not much different than we would do it on an in-person visit.
Anyone else? How are people tracking clinical outcomes?
Well, we spoke a little bit earlier about how we're utilizing our staff differently. We've actually used some of our sleep lab managers who especially are interested in more public health data. And they've sort of taken on a side task of tracking some of our outcomes in pediatrics, how many of our PCPs that screen for snoring end up referring to sleep, and how our insomnia patients are doing after their final follow-up. So we've actually been able to utilize some of our staff that maybe it wasn't as busy as they normally would to do some of the things that they're really interested in long term. One of them, I think, is now getting his MPH and kind of incorporating this project into his degree. So I think, all of us came in to sleep with sort of this long-term goal, and we've been able to help some of our team members actually access those goals.
That's great. We typically would have questionnaires for things like the Epworth scale here, and unfortunately, we found it very difficult because patients don't always fill them out if you send them ahead of time through the internet. So we're utilizing our nurses differently, getting at what you were pointing to. We have 2 LPNs that work with us in the clinic, and instead of doing vitals now for the telemedicine visits, because there are no vitals to do, they are literally going through the Epworth Sleepiness Scale and Insomnia Severity Index over the phone, and they're getting good now. I mean, they move patients through pretty quickly, but that's sort of something that's really come out of the situation, and we found that can be very effective. Nurses often will also enhance our visits. Sometimes patients will say something to the nurse, and the nurse will give us a heads up and say, hey, Mr. Jones mentioned to me he hates his masks. That's what you got to talk to him about first. And it's actually a help that we wouldn't normally have had. So it is very interesting how out of necessity springs some creativity. So that's great. And of course, all of our PAP machines are now downloadable remotely. So just like we would do before, we can remotely download and share our screen with the patient, and they can look at the results with us, and we can track that over time. So we're able to do that through Tele as well. So that's great. Let me ask Dr. Donskoy. So post-visit communications, how do you take care of post-visit communications and follow-up, like discharge instructions and stuff like that? How does that work?
Our team went through a number of different trials and errors until we really got this one right. Still work in progress. I think at the very beginning of the pandemic, we were physically printing out discharge instructions and mailing them. That went on for longer than I'd care to share. But soon after, we started using a HIPAA secure email that was provided to our department. So some of the nurses could send some of that communication. And then soon after, fortunately, our entire hospital system switched over to an electronic medical record that allowed for video visit functionality, meaning the entirety of the visit happened through this app or website the patient was able to download and have a login for. So now they would just activate themselves on this site or portal one time. And from then on, they'd be able to fill out all of the informed consent forms before the visit, which made that part of it quite a bit easier. They'd also be able to enter the visit and do the entire visit through that portal, which was linked to Zoom. And after the visit, they would be routed through the same portal. All of the after visit instructions, follow-up information, they'd be able to put in their pharmacy so that we could confirm that's where everything that needed to be sent was. And so everything sort of just became encompassed through this portal, which probably many of you have similar experiences with. What we found is that this is actually an amazingly efficient way to communicate with our patients, especially people who don't want to be on hold with the call center. So we actually encourage, because we've started doing in person as well, we encourage all of our patients to become enrolled on the portal, and we're able to send post-visit instructions when it's a telemed visit, but even when it's not, patients can send questions or concerns after the visit to our staff. We can answer them back. We can send sleep logs back and forth, which has been tremendously helpful for our behavioral health follow-ups. We're able to send lab information, sleep study results with comments. So now it's really sort of become how we're encouraging most of our patients to communicate with us.
Wow. It's sort of forced us to move into the future, even if we weren't necessarily thinking of doing it.
We probably should have been doing this all along. Yeah.
Right, exactly.
Everyone loses that discharge paperwork in the car anyway. So
Isn't that exactly? I know. So we really, I marvel that, the technology has been there for years, decades, right? I mean, it's not like the future. We've been able to do this for a long time, and now finally we were forced to use it. Anyone else having issues with post-visit communications or follow-up or discharge instructions, noticing how they can do things differently? No, yeah, I think it's a common theme that we're found different ways, and many of us like the new ways better. So we're going to keep them. So, I have one more question really here, and then we'll kind of wrap things up and ask a question to the whole group. But before we head toward the wrap up, I would like Dennis Kelley to help forecast the future. Why not? So I would ask him, how do you foresee incorporating telemedicine into the post-COVID world, which we will be in soon?
Well, I hope we are in the post-COVID world soon. I look at this as from a bipartite perspective, and that is I look at it from what's the potential for the future of telemedicine and what's the reality of it. And I think the potential is when we talk about, well, are we going to go back to where we were pre-COVID? And I think the answer to that is no, we're not going to go back to where we were pre-COVID. And I don't think it's just for telemedicine. I think it's for many, many aspects of our lives. Personally, I can't see that in the cough and cold flu season of next winter, 2022, that I won't be masking up just because it looks like it's a good idea and the science seems to, science seems to support it. So I think the potential for telemedicine is really great. I know that some of the sleep fellowship programs have had difficulty filling their slots in the past. I think that there are some physicians or fewer physicians that may be going into sleep medicine. And it probably has to do with, I remember 12 years ago when I started with Kingman, many of our sleep fellows came out and had positions that were 100% sleep medicine, and they were really thrilled with it. And now we tell our fellows, if you're looking for a sleep position and they're offering you 50% sleep and 50% whatever your other specialty is, grab it, because that's a pretty good deal. So, I don't think we go back for that. So I think the potential is great to provide greater access. I think it provides greater communication. And I think, at least from our personal perspective within the VA, patients love it. They're just really happy with telemedicine. They think it's more personal. They think it's as professional. It's easier for them. They don't have to necessarily drive into the clinic or travel distances. And I think that it offers practices the ability to expand their reach. So I could foresee that sleep practices, perhaps that were urban-based, coordinating and collaborating with rural practices, perhaps primary care providers, where we could provide this telemedicine sleep for them in their local communities, where patients wouldn't have to travel so far or be able to do this. And particularly with home sleep testing, et cetera, it even gives us another aspect where they don't have to travel. And I think, and Dr. Fields and I know, I think in the VA system, when you look at it, particularly when I look at VAs in the Dakotas or Montana, Idaho, where patients sometimes have to travel 2, 3, 4 hours to see a provider, whether it's a primary care provider or whether it's a sleep subspecialist. You know, telemedicine gives us the opportunity to provide that service to patients at home where they're comfortable and don't have to travel, and maybe more willing to be evaluated for sleep if they don't have to do this travel or they don't have to be inconvenienced for it. And so I think those are the potentials for the future. I don't think we're going back. I think the reality is we'll need to see what HHS does as far as reimbursement structures are. I know that we've had some changes as a result of COVID, but I think third-party payers are going to realize that this might be a little bit less expensive, so they might be in favor of this. I think providers are going to say they like it. It's favorable for the practices as well as for the patients. I think it benefits the patients. I think it benefits the practices. And so I don't see us going back. I think more and more technology is going to come out. All of us know patients that come in and they say, well, my Fitbit says that I only slept so many hours last night, or I woke up so many times. And, you know, initially we'd say, well, you know, the algorithms are okay with this. But, you know, at the last couple of sleep meetings, we've seen a lot of technology discussed. And I think that it's there and it's not going away. And I think we need to embrace it. And I think telemedicine is in our future. I think it's good for us, and I think it's good for our patients.
What do other people think? Any other thoughts about incorporating telemedicine post-COVID?
I mean, I would concur with everything that he said, is that I think from a provider side, a consumer side, a payer side, even large employers that may be self-insured, is that it's just going to become just another way to deliver services, but providing more options, because we kind of talked about earlier, is it's not well suited for everybody. It's not well suited for every diagnosis, but it does provide a wider array. So I definitely see that not only will telemedicine maybe increase, but if you think about access as well, if there are a limited number of providers, then even like digital solutions may actually increase as well. So algorithmic kind of medicine, if you will. So I think that will maybe advance a little bit further because of access issues and also people embracing technology a little bit.
Right. The wearable devices
Wearable
that
devices.
Dennis Kelley mentioned, and I know the AASM has worked with the committee on that. It's coming whether we like it or not. I mean, I could argue it's here, and we're going to have to integrate them.
Yep.
So maybe that forecasting is a good place to kind of transition toward our close. And in considering what our final question could be, I want to pose it to all of you. So think about, what do you wish you knew about telemedicine before starting or working in your program? What do you wish you knew that you want to make sure that our viewers of our chat know, so that they know even if you didn't? So let me start with Dennis Kelley. We were talking before. What do you wish you knew? And we'll go through this list fairly rapidly with the group here, but what is just something you wish you knew before you did start telemedicine?
I think I wish I knew that it wasn't going to be as hard as I thought it was going to be. I would say to people that haven't done it, jump in, the water's fine. It's not as hard as you think it's going to be. I wish I would have known that. I think I was a little hesitant with the technology because of that, but that would be my recommendation. Jump in, the water's great.
I agree. Dr. Martin, your thoughts. What do you wish you knew?
I wish I knew more about lighting and audio, really some of the more AV technical things, and to look at a certain place at the camera.
It's not necessarily intuitive, right?
No.
Really, yeah. Dr. Donskoy, what do you wish you knew?
You know, I echo that. I think telemedicine is incredible for patients as well as ourselves, but I actually also wish I knew a little bit of the other side of it. You know, we tell our patients all the time that they really should have their bed for sleep only, so that they have that tight association between relaxation and sleep and their home environment. But many of us are working from home. We're running our entire clinic, reading all of our studies, doing it all from the same place that then we are hoping to unwind and relax. And I think all of us probably have a shared experience where we're not relaxing. We're working a lot more. We're maybe doing it a little bit more efficient. We're certainly breaking that association that we probably need to have between our home being a place for us to unwind. Because, very, very quickly, I realized I needed to get up and stretch between patients. I needed to not have lunch in front of my computer. And I needed to, maybe instead of checking my email, just take a few deep breaths before moving on to my next patient. We can be so efficient. We can deliver this care, this quality care, so much more effectively with telemedicine, but we can't do it if we burn ourselves out. So I would say that understanding that work, home, fine line is really important for us as we do this.
Excellent lessons. Great. Dr. Wan, what do you wish you knew?
Yeah, I really wish I was better equipped with the resources I had available to me. I mean, now I found them, but back when we were starting, I mean, I think the resources have developed over time as well, as people get more experience and there's the need. But as you mentioned, the AASM already had their guidelines from a couple of years prior. It wasn't relevant to our practice at the time, so I didn't really refer to it. But I think had I known, I would have, I think, had an easier time transitioning our program.
Great. And we've had great reviews among several of you of the resources that are available now. So we can kind of luckily catch up. Dr. Troester?
Yeah, I think for me, I wish I had been a little more aware of my implicit biases. One thing about there's a very personal aspect to kind of inviting yourself into someone's home that's much more different than them coming to your office. And I think, I think the first time I saw one of my patients' houses, it was this, palatial home. And I was like, oh my gosh, your home is beautiful. And I realized that I probably shouldn't be saying that. It's probably completely inappropriate. I wouldn't tell someone that their home wasn't beautiful. So I probably shouldn't be telling them that their home is. And so I had to kind of realize that I'm a guest in their house and I have to mind my manners and things like that. So for me, that was something different. I've been doing telemedicine for like a really long time, but it had always been kind of someone came to a clinic to see me and it was never me going into their house. And so for me, that was different. It humbled me a little bit. I had to think about that. So I wish someone had told me to think about that before.
Absolutely. Before we wrap up, any last comments from anyone else on the panel about what you wish you would have known or any other words of wisdom? All right. Well, with that, we will finish our fireside chat. I want to thank each of the members of our panel from taking the time out of their very busy schedules to join us for a really informative discussion. I've learned a lot. And I also, of course, want to thank everyone who is taking the time out of their busy schedules to watch us. Good luck with your own sleep telemedicine journey, and check back frequently, as you've seen with the AASM website, for more tools and updates that will help you along the way. Best of luck. Take care.